Good morning, everyone. Welcome to another edition of Nursing Rounds. And this morning it gives me great pleasure to introduce our own director, Suzanne Campbell, talking about a topic near her heart. Feel free to help yourself to muffin and or coffee and tea. And Suzanne, I'll let you take it away.
Thank you very much. Thank you all for being here this morning. I didn't expect the room to be quite so full, and I guess I can't see who else might be online with us. But in light of what has occurred overnight in Brussels, I thought it may be appropriate to just take 1 minute to calm and center ourselves and send out some well wishes to those who have been involved. It's a worldwide ramification. So thank you for just a moment of silence. Okay, Elizabeth is right. This is a topic near and dear to my heart. You all know that I could probably stand up here for 8 hours and describe. I brought just a few of the texts that have influenced my scholarship of teaching and learning over time, and I will try to integrate them a little bit. What I was hoping to do today was talk more broadly about the methodology of simulation and flexible innovative learning styles as it relates to health professional development, get down a little bit concrete to nuts and bolts of how it might look a little bit different from a skills environment to a non-technical environment, and then open it up for discussion because it is a very controversial area right now with the research that is coming out and how we're looking at it. So I do have a disclosure. Let me just make sure that this is going. I am a co-editor for Simulation Scenarios for Nursing Educators, Making It Real. That means I get about $1 a book, and they only sell to nurse educators. So when Canada and the U.S. take the taxes out, I see maybe $300 a year, but I felt like I had to disclose that. We are in the midst of putting together the proposal by tomorrow for the 3rd edition, and I've been in touch with all of my authors, some of whom may be on this webcast this morning, and very excited because of course it's going to have an international flavor, and there's several folks here in Canada, especially BC, that are interested in writing chapters. But what I'm hoping to do is just talk a little bit about why we need to think about evolving technology in our health professional education and take a look back on the last 50 years of what has changed in nursing. I think it might surprise you a little bit. I will differentiate how you might use simulation for technical versus non-technical skill advancement, and I gave some examples of clinical skill, teamwork, conflict resolution, leadership, and role development, and that's how I'll tie it in with interprofessional, and then outline some of the uses we've seen for health professional education. But I also want to just touch, because it's a topic in and of itself, the idea of actually substituting lab or campus-based activities for clinical practice activities. I want to look a little bit at how we're beginning to standardize case studies and scenarios and to share them globally. And then finally, just compare and contrast the advantages and challenges for nursing specifically of how we're using simulation right now. So this may feel like old material, but the Lancet report that came out in 2010 from the Institute of Medicine, Canada was one of the leaders in this report, looking at the need globally for health professional development. And basically, they were looking at health professionals for the new century, and they looked back over at least to half a century to a century at our focus on very concrete scientific knowledge to where we've gone now with the complexity of clinical decision making and critical thinking. And they were hitting at this point in time that call to all of us that we belong to an interdisciplinary team in healthcare and that we need to be looking at evidence-based practice, the use of technology, and quality improvement in our care. There is a long history, and I think that we can share these slides because I've embedded a ton of links. I don't think with the time given I will go out to each of them, but there's a long history of interprofessional education in Canada, and I only grabbed the last 10 years worth, but we really have been leaders here with what we're doing, and it just talks about that interprofessional component. Of course, Ontario was leading on the east side, but Maura was involved very much with Leslie Bainbridge and our group here at UBC as part of the broader pan-Canadian group that worked on it. So here are the top changes in the last 10 years. I love Angela Barron McBride. She came up with this in 2011. But we know nursing is not one kind of a job. Nurses head into leadership positions in all sorts of areas. We have a growing global acceptance of the role of nurses in leadership in healthcare for developing safe practice environments and quality care. We've had an informatics revolution. We're emphasizing on outcomes and data. We are developing centers for nursing excellence. And when I look even across UBC School of Nursing, all of the centers that we have running that really have excellent and broad nursing research programs, that whole research base of nursing is becoming visible. Our advanced practice nurses are gaining in ability of what they're doing, their integration with research and use of data to drive practice. And take a look at our nursing students, especially here at UBC. We have diverse ages, genders, races, and learning styles, and that's what I'll be hitting on today. But we're also articulating across all levels of nursing so that we become more user-friendly. I think when we look at our internationally educated nurses and see where they can immigrate into Canada at a different level than maybe what they were trained for, and then articulate through our education programs here to gain more skill and move up the ladder in nursing. And we know that we're bringing people into nursing as adult learners from very broad varieties and background experiences. And then finally, we all know about the information explosion and how our literature has expanded. So what is the paradigm shift for nursing education? We're looking more closely at how we most effectively use nurses at the level that they should be at. What is the knowledge? What is their education? What are the skills that they bring to that situation, that population, that context? We've got to look at configuring the nursing workforce and do succession planning. I get a little disheartened when I think of the gray wave of nurses, and that's what we're called, but nursing is aging, and we need to attract new and energetic folks and folks from all backgrounds. And then enhancing our knowledge base will continue, and here in Canada we're doing that by requiring the baccalaureate as entry to practice. I just wanted to share up-to-date wise, this call came to me yesterday. There's a health professions education network forming. This one specifically is a Saudi-Canadian combination, but we have been approached before, and it goes back to that Lancet mandate that, you know, in North America, even though we claim a health profession shortage, compared to other places in the world, it is not. And I think ethically, we need to be really careful as we draw from other places that we're not draining their capacity to meet our own needs, and how instead do we do capacity building. So the WHO Collaborative has many practice domains here. I will be pulling out the teamwork, roles and responsibility and communication, but these are 6 core areas when they look at interprofessional practice and how health professionals work together that they focus on. And I like going with the World Health Organization because it's global. So simulation has evolved a little bit, and I'm sorry for all of those who have seen this slide before, but I love the contrast of the wooden horse that was used in World War I, I believe it was, to train the cavalry to ride. down to, up-to-date NASA space shuttle type of interior. But we know that simulation is an acceptable form of healthcare education. We're using it with health professionals for both technical and non-technical skills. And technical, we can look at assessment, putting in catheters, starting IVs, even with our more high fidelity human patient simulators, listening to heart sounds. I have to say there's a new stethoscope out called the ventrilocutor. I had it wrong. I was calling it ventriloquist, but the standardized patients hold it in their pocket, and when you're listening to their heart, they make it be the heart sound they're supposed to have for the condition they have. And they had lungs and bowels, and it's, just one set that the student can wear, and it doesn't matter where they place it because they're controlling it in their pocket. So I'm looking with pharmacy and a couple of other groups that may be investing in one of those. But how do we get at the clinical decision making, the communication that occurs, thinking, acting, reflecting like a nurse? How do we get at that teaching our students? We need to look at theories, and there are many different theories that are guiding simulation case development and research in the scholarship of teaching and learning. Bloom's taxonomy, and I'm just going to go through these quickly as ideas, but I will show you how that has morphed from 1956 to now. Bandura's theory of self-efficacy, I think, has real components. I know we've looked at it ad nauseum, but of the three areas in Bandura's theory of social cognitive theory, actually self-efficacy is one of the only ones we can have an effect on. We can give people the knowledge and skills they need through vicarious experience, through persuasion, through just basic knowledge, reading and watching videos, that they then can practice a behavior and get better at it. So for the technical skills, that might fit really solidly, but I think we need to think about it a little bit more broadly when we're thinking about actual clinical decision making and critical thinking in the moment. Benner's, I dragged out, I think I got another copy. I don't think that's from my 1980s master's degree, but novice to expert has been around and developed into a theory, and we know that it makes sense for us. I think it helps remind me as an educator of where my students are starting. And then Cole's experiential learning theory, a graduate student at University of Toronto used that to develop a conflict resolution scenario and really did some expert testing with it so that she'll be ready to go to randomized controlled trials to actually be able to provide a scenario and situation where she can evaluate how the students are managing conflict resolution. And finally, I had to throw in my little framework theory because that's the one that I've been working my research off of. So here's just an evolution of Bloom and how that has transitioned from 1956's very specific cognitive, psychomotor, affective sciences to the more 2001 taxonomy. We're not throwing out the factual knowledge. We know that aspect is important both conceptually and concretely, but we know there's also a procedural knowledge that goes along with that, how you prioritize, what you do first, how you're evaluating that subjective and objective data that you're looking at. And then there's a whole metacognitive knowledge, what the perception is, what the context of the situation is, not just for the health professional and our students, but also for the patient who is living in that environment. And I just gave an example, the quality and safety education for nurses. We're looking at that right now for our undergraduate program. But that ability to separate out knowledge, skills, and not forget about attitude, because it can have huge components. Underneath that, you can see how Anderson, Krathwohl, Bloom, and Cronenwet kind of used a similar model to look at nursing skill development and clinical judgment in simulation, and taking clinical judgment with components of critical thinking, how students problem solve in the moment, actual hands-on psychomotor skills that they need to integrate, and clinical reasoning. When I look at the complexity of what we're trying to teach our students, it's, no wonder to me that it is enjoyable and challenging and wonderful, but to get them from that novice level to a level where they have the foundational information they need and situational exposure to become expert nurses is a lifelong process in my mind. I really like Kolb, and it's interesting because there are so many different varieties. He really started in 1974 with some of these components, but it's been so interesting in the literature to see how this cycle of experiential learning has evolved, and for me it fits beautifully within simulation. Students have to have a concrete experience. They have to do, act, connect hand, body, and mind. But then they have to reflect on it and look back at why did they do something the way they did? Why did a colleague choose to do something else differently? And try to abstractly conceptualize that into their body. And that's where some of the readings on the mind, the mindful brain and the art of the changing brain, this is Siegel and Zoll, were really helpful to take a look at how that brain takes information, how it makes it into memory that can be called upon when similar situations occur. And again, that with simulation, we're storytelling like we've done with our case studies in nursing over time. Finally, you want to see an active experimentation time. They tried something, they're going to do it different. And so learning is the process whereby knowledge is created through the transformation of experience. When I look at myself as an educator and researcher, I think about the fact that I want to design a learning experience for my students that will help them integrate the knowledge they need, become the expert nurses, and then I want to be able to evaluate and assess that it made a difference. And it was no different from them watching a video in a back room. The framework for simulation learning you've seen a little bit before, and really it is just taking into consideration the culture, individual experiences the student brings to the situation, how they're learning within a digital environment, and what they might bring to the learning experiences. And that could be positive and negative background situations. But if we identify that thinking critically, intervening therapeutically, and communicating effectively are three key areas, in my mind, simulation sits in the triangle in the center, and they can reach those areas at that time. We want to see safe practice, which is vigilant and excellent, and we want them to become reflective practitioners. The benefit in simulation is if it doesn't go well, they can come back into this scenario and practice it again until they get it right. So are there similarities and differences between the simulation scenarios we're developing today and case-based learning? I think there are a few. The similarities are we've identified the objectives for learning that the students will be using. We're giving them a story with key information. We tend to call it the medical history or social history or a background report. We focus on critical thinking. We want the students to be digesting and using all of their senses in the moment to gather the data they need to act. And there is a fluid dynamic process. I think one of the most frustrating things for students in our multiple choice exams don't help is there is no right answer. And depending upon the context of the situation, and I can say that very loosely because we know there are situations where there are right answers. But the differences, I think, are when we're dealing with healthcare and the context of not only the people being human beings, but the people we're acting on being human beings in an environment that often we don't have a lot of control over, we're using it as a method for teaching in unpredictable situations and events, and sometimes chaotic. There's a variety of confounding variables that really we will not be able to ever 100% control, and it tends to be a very quick time frame. Things happen quickly. It does tend to be more individually focused, but I'll give you an example where we can move it to the system organization level. And we do need to prioritize actions. When a misstep is made, adverse events can happen, and worst case scenario, the patient can die. In a simulated environment, there was a lot of controversy 10, 15 years ago about whether we as instructors should allow the patient to die. And I think we realize today that that's not always a bad thing. Better in a simulated environment and help the student to process through the potential of that reality so they're not devastated in a real situation when it happens. If we move this concept of simulation into interprofessional education, it has a huge place in my mind. And this is the simple definition of IPE that I think most of you have seen before from the World Health Organizations, and it is 2 or more professions. And I want to challenge us. Our external reviewers mentioned that we do need to be thinking a little bit more broadly as a school about interprofessional, and it's not just other health professionals. It's our architects, it's our engineers, arts folks, and people in other areas. There are key elements, that 2 or more professionals, but it's interactive. So you can have a didactic component to it, but it should have an experiential component. And the critical reflection of learning really happens in the debriefing. And this is an area in working with nursing faculty that I think sometimes I watch the seasoned nurses with a lot of experience, and usually debriefing is just like breathing air. It's not a big deal. But for our novice learners, this is an area, our novice new teachers, that we can help to build up their confidence in what they're doing. So this is a very busy slide, I'm realizing now. I just wanted to give you some examples of where simulation pedagogy could be used to integrate interprofessional, and it can be done throughout the curriculum. We have examples here with our passport experiences, our medication reconciliation, NPs, pharmacists, medical residents, our patient handover experiences, and teamwork in trauma scenarios is another example. I have seen people go out broadly and bring in your hazmat groups, your first responders, and that type of thing. I think our fellow nursing programs have access to some of those folks. And then our health mentor model is a great model of integration of interprofessional education. But we can also do it competency-based and test at various points throughout the curriculum at the end of a term or beginning of a term and do comparisons there. And there you would have very specific evaluation criteria related to teamwork and communication and assessing and understanding each other's roles. But it also can be concept-based across the whole curriculum, and iEthics is a good example. We're looking at health informatics right now. I think communication and cultural sensitivity and humility are all areas where health professionals can come together to learn interprofessionally. Scherer did a study of interprofessional practice simulation with medical residents and nurses, and he found that it really did foster collaboration when he looked at 3 subscales, and that is the readiness for interprofessional learning scale, teamwork and collaboration, professional identity, and even the roles and responsibilities. And this is what I've seen in the Health Mentor program in participating in their projects at the end of the year, that they really have gained an idea of what the other roles and responsibilities of healthcare practitioners are. So I want to dive into a specific example. I'm choosing postpartum hemorrhage because obstetrics is my background, and this is still the leading cause of maternal death worldwide. 35% of all maternal deaths are related to postpartum hemorrhage. And if signs are caught quickly and action is done, even in remote areas, it can save a mother's life. So I took what I created for undergraduate nursing students to learn just very basics how to go through, and I moved it into, and when we're looking at those undergraduate students and the experiences that they need to have, there's often choices of different areas. What might we do? Examples I have are a diabetic mother who has a 4.3 kilogram baby that's showing signs of hypoglycemia. When the student gets into the scenario, they don't know. It could be infection, ruptured membranes for a longer period of time, or it could be our respiratory distress or the hypoglycemia. The postpartum hemorrhage is the one I'm going to break down for you. There also was a scenario in pediatrics with an 17, 18-year-old who had been kind of told the treatments had been exhausted for their leukemia, and the students go in to speak with them after that. And finally, first trimester bleeding, I would compare a miscarriage with a hydatidiform mole. So the reason I'm identifying these 4 areas, they're all areas where crisis could be happening, active bleeding, respiratory distress, end-of-life scenarios. Teamwork could be involved, or just a one-on-one, how do you teach a student the basic skills for in the moment, and related to either palliative care or end-of-life discussions for students. So in the simulation postpartum hemorrhage, I just want you to focus on the left-hand side there. You identify who are the participants in it, what is the process of how the situation will roll out, at what point do they enter the situation and leave it. You need a little bit about the patient history, and then I like to give the students some expectations, especially at the undergraduate level, of what they might do when they go in. And up front, if you are setting up the scenario for a clinical skills environment, that's the type of template you can follow to set the situation. If you're setting it up for a team or leadership experience, it will take on a different perspective. The objectives you develop for both will be different, the prerequisite learning will be different, and the outcomes you expect will happen differently, as well as the debrief focus being different. So in the development itself of simulation scenarios, we are moving into a time period where we have standards of best practice now. And Axel just released in 2015 the Simulation Enhanced Interprofessional Education and the Simulation Design. And I just identified MECM for that first one, but the first 7 of these are in a 2013 journal article, each separate with a whole slew of different authors for them. They are not rocket science, I think they're just giving the research background and the steps for people to identify what we have been doing in developing scenarios overall. But I thought I would pull out this criteria for the simulation interprofessional. They're saying to achieve optimal outcomes, we need to base it on a theory. That's why I showed you some examples of theories you might use. You need to follow the best practices in simulation-based and interprofessional education, and address anything that's going on institutionally or locally as you're rolling out that situation, including an evaluation plan at the end. Those are not difficult criteria. It almost feels like a no-brainer, but to have it written down and to have steps, and that second one, the best practices for simulation, there's a best practice for simulation design. That's a template I created for the textbook as well, just to give people guidelines of what's important to include and be thinking about as you're using this model. The simulation design one has very specific areas, and again, this has morphed over time from Pamela Jeffrey's early work on simulation. We just have it written concretely now. So if I compare the postpartum hemorrhage and the undergraduate student, what will I be looking for? I want them to be able to obtain a patient history, demonstrate that they can make an assessment, examine what factors are putting this person at risk for the hemorrhage, and identify signs and symptoms of the emergency. Then they should be able to do the specific focus physical exam and debrief using the self-reflection tool component. If I'm doing it for team building and leadership, I'm going to have very different objectives. I'm going to need to focus more on how do the team members collaborate and delegate? Do they identify a team leader? How do they outline emergency procedure steps between themselves and correctly communicate that as they go? How do they get other staff involved and that role of the leader, how is it being enacted? And then how do they mobilize the whole team to keep the mother and infant safe? The debrief will look very different because it will be self-reflection. You might want them to develop a concept map specific to their role in that situation, and you'll want them to provide feedback to each other of how they worked as a team. I think one of the best examples of this was the birth study out of the United Kingdom, where they took the limbs and things model that I've used in the past for shoulder dystocia, and they actually went from obstetric unit to obstetric unit, and they demonstrated increased better outcomes for the mothers and decreased bad outcomes for the babies. So that's the type of team building experience you can get. So if I yank out the objectives, how might they differ from a clinically driven scenario to one focused on teamwork, leadership development, or communication? For clinical, demonstrate the assessment. For communication, educate the patient and partner as things are happening, and that's something that we often forget about and have demonstrated in the research that leads to traumatic post-recovery for a lot of people. And finally, for interprofessional, an objective could be that you want them to maximize the team for maximum safety. It could involve all of the above components. The prerequisite learning would also be different. For the undergrad, very concrete, you want them to review a basic assessment, but then be able to differentiate what could cause a crisis situation in a postpartum patient and think about all the different areas. There might be a video to watch, there might be an online quiz, all as prerequisites before they go into the experience. With the leadership building one, I find you often are working with practicing clinicians and they don't have that preparatory time. So you need to be doing more on the fly, which means sitting down with the whole group before and reviewing it in detail. And an example I give is I did this with a group of Royal College physicians and surgeons here in Vancouver, and they hadn't thought about postpartum hemorrhage in 10, 15 years, some of them. They just weren't working in that area. So I had to make them comfortable with that whole concept and what would be expected of them before they could focus on the communication of the moment of how to act together as a team. Walking through the room, pointing out where things are located and what they might find. Those are all ways that it just allows for smoother enactment. And then finally, the outcomes will be different. For the student side, it will be very concrete as to what we're expecting in their objectives, whereas for the team building side, we're looking more at collaboration, communication, and the debrief with each other as to how they inform each other of how they could act better as a team in the future. I gave us example of some debrief questions, and the hard part I find in using simulation as an educational tool is when to sit on your hands or put duct tape on your mind and let the process lead so that they actually get to explore. And I also find if they're given some quiet time first to jot ideas down and think about why they did certain things in which order or why they might have forgotten something or not, it's helpful. For the team building one, having them look, again, journaling can be helpful, but having them look at the kind of communication they might have used with the family. Was it effective or not? What might have worked better? Looking at how they might have changed their style of communication between colleagues and families. Was there a hierarchy playing out? Was there a power structure going on in the scenario which could have put the patient at risk? And then how did they work? How did that work to create barriers or opportunities for a smooth transition? So I think you get the idea of how it could be different. There are debriefing questions in common, and oftentimes you like to start with these just to get people settled a little bit. What surprised them about it? What did they think was challenging? I think the surprise one, especially for the postpartum hemorrhage of the hundreds of students I used it with, was they were surprised at how quickly things went bad. And when we think about nursing in general, healthcare, I think that's a common theme throughout many areas, and especially they tend to be more surprised when it's a healthy, normal woman who just had a baby and all of a sudden she's in crisis and could die. You also want to look at what confused them, because those could help to pinpoint other areas for learning that they could use, and then go through some of the teaching components. So it can be used to jumpstart a whole learning experience in a classroom. It can be used to assess or evaluate at the end that the student has the skills that they need. And I'm looking at the time quickly here. I do, in my chapter on this, provide teaching notes for the teacher. So here are areas about the scenario that put the patient at more risk. Here are things you might want to include, and that's making it a little bit more like a case study. So there are examples. I gave you a very concrete clinical example, but it can be done interdisciplinarily and interprofessionally with multiple patient medical surgical scenarios. The student nurse resident team one, and again, these are all just chapters out of the book, was a really neat pilot project. What do you think the major barrier was for that one? It's a major barrier overall for simulated learning. Where are student nurses? Where are medical residents? How do you get them together? How do you find the time, the space, and the opportunity to bring them together? The operating room fires and the quality and safety improvement were both with nurse anesthetists. And then a hospitalized older adult, we switched the version for an undergraduate focus and then actually had a nurse practitioner focus. So you can elevate the level of skills and the expectations of the practitioner depending on what you're doing. So here's where we come to some potential controversy. There are lots of opportunities for standardization today. How are we standardizing these? Do they need to be standardized? Does Catherine Sim Center and ours here have to be certified and approved and accredited? They're all things I think that we need to look at. You'll notice right now there's a lot coming out of the U.S., but they're also in Sydney and Toronto. In Cape Town, South Africa, they're building a simulation center that will be up to standards. And there's also opportunities for faculty to become certified as simulation educators. We have a few folks here in BC that are going through some of these programs. But as far as nursing simulation research, there are still gaps identified. I think it's the Kaken and Atwood study that looked at over 100 nursing simulation research studies, and embarrassingly, I don't want to say the wrong number, but like less than 10 used theory, less, they really didn't have outcomes that were measured by reliable tools. So focusing more on outcomes, that student learning that we claim is occurring, did it actually occur, and how are we measuring that and differentiating it? Not good enough just in the simulation lab. It has to transfer to their clinical practice and to their development as professionals. Looking at how we design simulations, the setting we're providing it in, who are the participants and facilitators, and just increasing our research rigor. I don't think it's a surprise to any of you that time, resources, and support tend to be the major gap. I think one of the largest elephants in the room for us when we're looking at interprofessional practice and developing not just our future pre-licensure health professionals, but also those who are out in the trenches, is we don't see a large incorporation of interprofessional practice in our practice sites. The fee structures here and in most other countries don't support this. And then we do have to consider how we prepare the already practicing professionals. So I think there's many opportunities to bridge the education practice gap, to create innovative learning opportunities, but we do need to be considering standardization, assessment, and evaluation, and I think we can do that on our own without all these heavy certifying bodies, but there are key elements to interprofessional, and that is 2 or more professionals from different disciplines, and I challenge us to think outside of that in working with some of the visual and performing art folks and actors. They bring a lot. I think we need to look at our retired health professionals. They're dying to work with our students and bring them in as live actors. And then that interactive learning experience that might have a didactic or group component before we actually have the experiential, and taking time for a critical reflection of the learning afterwards, because debriefing really depends on what were your objectives for that situation, where were you trying to get to, and then what actually happened in the context of it. If it went really badly, that's not necessarily a reflection on you. It can be used to tweak how things went. It might have been a bad day for the students. How do you debrief with them so that it doesn't leave a bad taste in their mouth and they don't want to learn this way again? And then I think we need to proceed with caution when we're using theory and looking at this substitution of clinical with simulation. I think that just to go across the board and say, oh yes, we're just going to all do this without some standards of how we're evaluating the simulation we're using, how it's being enacted, how the folks using it are trained, and having some levels to make sure that it's meeting necessary standards is important. And I think if we focus on competencies and learning outcomes rather than hours, we'll be a lot better off. I know our regulating bodies want hours and want a number of hours, but I don't think that's necessarily where we need to go. So I just want to peek at the end and show you that I did identify some of the interprofessional organizations, and then I have references of key papers for interprofessional, but then also for the simulation components that I had in. So I'll go back up to the pretty picture. That's it in a nutshell.